Hey everyone, welcome to EM Journal Club. I'm Thomas Vu, an emergency medicine physician here at Kaiser Downey Medical Center, and this is our very first episode of many more, hopefully. The goal of this series is simple. We're going to take a practice-relevant journal article and break it down in about 15 minutes and walk through what it means for the practice of emergency medicine. We want to help you stay up to date with current evidence and best practices while earning CME credit in a format that's digestible, user-friendly, and maybe even a little fun. Each episode is paired with CME credit, and I'll show you exactly how to claim yours at the end of the video, so stick around for that. Before we get started, disclosures. I have no relevant financial relationships or conflicts of interest to disclose. All right, let's get into it. Clinical scenario. Okay, imagine a sister hospital in another state gets hit by a natural disaster. They put out a nationwide plea for physicians to help staff their emergency department. You've got some time, so you go volunteer. On your very first shift there, you get a stroke alert. Patient arrives with focal neurological deficits, last known well 2 hours ago. CT is negative for hemorrhage. This patient needs a thrombolytic. You turn to the nurse and say, "Let's get that thrombolytic going." The nurse looks at you and says, "Sure, which one?" "We carry both Alteplase and Tenecteplase." You pause. Back at your home institution, you've only ever had one option on the shelf, so you've never actually had to make this choice. And then the patient's daughter, who happens to be a nurse herself, asks you, "Doctor, what's the difference between the two? Which one is better for my mom?" Now, you're on the spot. What are you going to do? That's what we're going to answer today. Learning objectives. By the end of this episode, you should be able to 1. Compare the key differences between Tenecteplase and Alteplase. 2. Summarize the design and findings of the ACT trial. 3. Discuss the clinical implications of Tenecteplase adoption in your emergency department. Background. So let's set the stage. And before we dive in, a quick note on terminology, because you're going to hear these drugs referred to in a few different ways. Alteplase is also known as TPA, or by its brand name, Activase. Tenecteplase goes by TNK or TNCase. You may hear me use these interchangeably, and you'll definitely see them used interchangeably in the literature. Same drugs, different names. Alteplase, TPA, has been the standard IV thrombolytic for acute ischemic stroke since the landmark NINS trial back in 1995. It works, we know that. But after 30 years, we also know its limitations. The dosing is weight-based, 0.9 milligrams per kilogram, with 10% given as a bolus, and the remaining 90% given as an infusion. That means you need an infusion pump, you need a nurse dedicated to monitoring it, and if the patient is being transferred for thrombectomy, which is increasingly common, you're managing an active infusion during transport. If the infusion gets interrupted, you're not sure if the patient got the full dose. There's real room for error there. Enter Tenecteplase, TNK. It's a genetically engineered variant of Alteplase. Same family, but modified in 3 places on the molecule. These modifications give it 3 important pharmacological advantages. Let's take some time to nerd out about these differences. First, it has greater fibrin specificity, meaning it's more targeted at the clot and less likely to cause systemic fibrinolysis. Second, it has a longer half-life, about 20 to 24 minutes compared to Alteplase's 4 to 5 minutes. The longer half-life allows it to be given as a single IV bolus. No infusion, no pump, 1 push, and you're done. Third, it's more resistant to plasminogen activator inhibitor 1, or PAI1, which means it's less easily deactivated once it's in the bloodstream. Now, Tenecteplase has been the preferred thrombolytic for heart attacks for years, It replaced Alteplase for STEMI a long time ago. And for stroke, we didn't have the large phase 3 data to support making the switch until this trial. There were smaller studies that built the foundation. The Extend IA TNK trial in 2018 showed superior reperfusion with Tenecteplase before thrombectomy. The NORD test trials explored dosing, but none of these were the definitive, large-scale, head-to-head comparison the stroke community was waiting for. That brings us to the ACT trial. Introducing the paper. So, for our very first episode, we figured we'd start off with something totally non-controversial: lytic therapy in ischemic strokes. Nothing divisive about that at all. No strong opinions in any emergency department ever. Alright, let's talk about the paper. Menon BK et al. Intravenous Tenecteplase compared with Alteplase for acute ischemic stroke in Canada, ACT. A pragmatic, multi-center, open-label, registry-linked, randomized, controlled, non-inferiority trial, published in The Lancet, July 2022. Now, the trial is called ACT, ACT, which stands for Alteplase compared to Tenecteplase. I'll be honest, when I first saw this, I assumed the C stood for Canada since it was a Canadian trial. It doesn't, but it probably should. The study question, in plain language, is Tenecteplase given as a single IV bolus at least as good as Tenecteplase for acute ischemic stroke? Notice, it's a non-inferiority trial. They weren't trying to prove Tenecteplase is better. They were trying to prove it's not meaningfully worse, and that's an important distinction we'll come back to. The paper, design and methods. Study design. This was a pragmatic, multi-center, open-label, blinded endpoint, non-inferiority, randomized control trial. Let's unpack all that. Pragmatic means they designed it to reflect real-world clinical practice, broad inclusion criteria, real ED patients, not a highly selected, cherry-picked population. Open label means the treating physicians knew which drug the patient received. That's a potential source of bias, but it's offset by the blinded endpoint piece, meaning the people assessing the outcomes at 90 days didn't know which drug the patient got. That's where the bias matters most. Registry linked. It's a clever efficiency feature. They linked trial data to existing stroke registries to capture outcomes, which kept costs down and reduced loss to follow-up. Setting. 22 primary and comprehensive stroke centers across Canada. Population. Adults 18 and older with acute ischemic stroke presenting within 4.5 hours of symptom onset who were eligible for IV thrombolysis. Between December 2019 and January 2022, they enrolled 1,600 patients, 816 randomized to Tenecteplase, and 784 to Alteplase. After consent withdrawals, 1,577 were included in the intention to treat analysis. The median age was 74 years. About 48% were female, 52% male. Intervention. Tenecteplase 0.25 milligrams per kilogram as a single IV bolus, max dose 25 milligrams, versus Alteplase 0.9 milligrams per kilogram, 10% bolus followed by a 60-minute infusion. Primary outcome. The proportion of patients achieving a modified Rankin scale score of 0 or 1 at 90 to 120 days. And this is a good time for a sidebar. Sidebar, modified Rankin scale. If you read stroke literature, you're going to see the Modified Rankin Scale, or MRS, in virtually every paper. It's a 7-point scale that measures disability. 0 means no symptoms at all. 1 means no significant disability. You have some symptoms, but you can do everything you used to do. 2 means slight disability. You can't do everything you used to, but you can take care of yourself. 3, moderate disability. You need some help, but you can walk on your own. 4, moderately severe. You can't walk without help, and you can't take care of your own bodily needs. 5 means severe disability. Bedridden, incontinent, need constant care. 6 means dead. In this trial, the primary outcome was MRS 0 to 1, meaning the patient is essentially back to their pre-stroke baseline. That's a high bar. Some trials use 0 to 2 as a good outcome, which captures more patients. When you're reading stroke trials, always check which cutoff they're using. It matters how you interpret the results. So, what did they find? The primary outcome, modified Rankin 0 to 1 at 90 to 120 days, was achieved in 36.9% of the Tenecteplase group versus 34.8% of the Alteplase group, a little more than a third of each group. The unadjusted risk difference was 2.1%, with a 95% confidence interval of negative 2.6 to positive 6.9. Okay, the key number, the lower bound of that confidence interval, was negative 2.6, which is above the pre-specified non-inferiority margin of negative 5%. So, non-inferiority was met. And if you look at the numbers, Tenecteplase didn't just meet the bar, it actually trended slightly better numerically. Though the trial was not powered to demonstrate superiority, and the p-value for superiority was 0.19. Now let's look at safety, because this is where you'd expect to see a trade-off if there was one. Symptomatic intracranial hemorrhage occurred in 3.4% of Tenecteplase patients versus 3.2% of Alteplase patients, essentially identical. 90-day mortality, 15.3% versus 15.4%. Again, no difference. So, the bottom line from the results, Tenecteplase performed at least as well as Alteplase for functional outcomes with the same safety profile. No more bleeding, no more deaths, and it's just a single bolus. Limitations. Now, no study is perfect, and any good journal club means we appraise the evidence critically. A few limitations worth noting. First, it was open label. The treating team knew which drug was given, which could theoretically influence downstream decisions, like how aggressively they pursue thrombectomy, for instance. The blinded outcome assessment helps, but it doesn't completely eliminate this concern. Second, the non-inferiority margin of negative 5% is somewhat generous. Critics have argued that a higher margin, say negative 3%, would have been more reassuring. However, the actual result, negative 2.6% lower bound, would have met an even stricter margin. So in practice, this is a minor point. Third, this was a Canadian study, 22 centers, 1 country. Does it generalize? Biologically, there's no reason to think it wouldn't. And importantly, subsequent trials have confirmed these findings across different populations. TRACE-2 in China, Original in China, and ATTEST-2 in the UK, all showing consistent non-inferiority. And fourth, the trial was not powered for superiority. The numerical trend favoring Tenecteplase is interesting, but we can't conclude from this single trial that Tenecteplase is actually better. That said, a 2025 meta-analysis pooling 11 randomized controlled trials with over 7,500 patients did find a statistically significant advantage for Tenecteplase in achieving functional outcomes that were excellent. So, the totality of evidence is building. Analysis and impact. So, what does this mean in practice? This trial, along with the subsequent confirmatory trials, has fundamentally shifted the landscape. The 2023 European Stroke Organization guidelines now recommend Tenecteplase as an alternative to Alteplase. Health systems around the world are actively making the switch, and the practical advantages are substantial. A single IV bolus means no infusion pump, no 60-minute drip to manage, and no risk of an interrupted infusion during transport. For drip and ship scenarios where you give the thrombolytic and then transfer the patient to a thrombectomy center, this is a game changer. The drug is fully on board before the patient leaves your emergency department. It's simpler to dose, simpler to administer, and there's less opportunity for medication errors. And in many markets, Tenecteplase is less expensive than Alteplase. So we're looking at a drug that's at least as effective, equally safe, easier to give, and often cheaper. That's a compelling case for change. Clinical pearl and takeaway. Here's your clinical pearl, the one thing I want you to remember. Tenecteplase for stroke, 0.25 milligrams per kilogram, single IV bolus, max 25 milligrams. No infusion, no pump, that's it. Let's review the key takeaways. 1. Tenecteplase is non-inferior to Alteplase for acute ischemic stroke within 4.5 hours with equivalent safety. 2. The single bolus administration offers major workflow advantages, especially for transfer patients. 3. Multiple large trials and a meta-analysis now support this finding across diverse populations. 4. Guidelines have been updated to reflect Tenecteplase as a recommended alternative. Closing. So, let's get back to our scenario. You're in that unfamiliar emergency department. The nurse asks, which thrombolytic? You now know the answer. Tenecteplase, 0.25 milligrams per kilogram, single bolus. And when the patient's daughter, the nurse, asks you what the difference is, you can confidently explain that multiple large trials have shown Tenecteplase is at least as effective as Alteplase, with the same safety profile, and it's simpler to give. You're not guessing, you've got the evidence. Now, if you'd like to earn CME credit for this episode, here's how. Visit our website, I'll put the link on the screen below. Create an account, log in, and you'll see this episode listed. Read the primary article, I've got it linked right there on the page. Look for and click the CME survey link near the bottom of the episode page to fill out. Once done, this episode will be marked as complete so that you can keep track of your progress on what episodes you've already seen and have gotten credit for. Bookmark the site. We've got more episodes coming, which means more opportunities to earn CME credit on topics that matter to your practice. Thanks for watching the first episode of EM Journal Club. I'm Thomas Fu, and I'll see you on the next one.